Hi everyone, welcome to the online medical imaging class. My name is LIN. I'm a radiologist from the second affiliated hospital of Sciental University Medical College, China. In this session, I will introduce the diagnostic imaging of osteosarcoma. Osteosarcomas are malignant bone-forming tumors. They are the second most common primary bone tumor after multiple myeloma, accounting for around 20% of all primary bone tumors. They can be classified into primary and secondary forms, as well as the histologic types, of which conventional osteosarcoma is the most common. Secondary osteosarcoma occurs in the elderly, usually secondary to malignant degeneration of Paget's bone disease, extensive bone infarct, post-radiotherapy for other conditions, or as a differentiated cholangiocarcinoma. Patients often present with local bone pain, occasionally accompanied by a soft tissue mass or swelling. Sometimes the first symptoms are related to pathological fracture. We see this tumor in young adults, with 80% of cases between 10 and 30 years old, and most commonly affecting the metaphyseal lesion of the distal femur or proximal tibial. However, it can cross the growth plate with epiphyseal extension, as seen in 75% of cases. Based on anatomical relationship to the bone, we can classify osteosarcoma into central type, intercortical type, surface type, and extraskeletal type. Plain radiograph is the most useful examination for bone lesions. Hallmark of osteosarcoma is the production of bone matrix, which is reflected by the sclerosis seen on X-rays. Usually, typical malignant features including permeated moth-eaten bone destruction, irregular cortical destruction, aggressive periosteal reaction that is perpendicular to the surface, and a soft tissue mass. Occasionally, osteosarcoma may present as a lit or mixed lytic sclerotic lesion. What is periosteal reaction? Dr. Ma already introduced it briefly in the last session. It is a non-specific radiographic finding that develops with periosteal irritation. They can be characterized as benign or aggressive based on the time course of the process. A benign one arises from low-grade chronic irritation, which allows time for the formation of normal or near-normal cortex. The cortex can be thick or dense and have a very or uniform appearance, like the image on your left. Aggressive periosteal reaction comes from rapid irritative process, which do not allow the periosteum time to lay down or consolidate new bone to form normal cortex. The cortex may appear laminated, onion skin-like, sunburst-like, or forming a common triangle. One can find aggressive periosteal reactions not only in malignant tumors, but also with more benign processes like infection, trauma, etc. A common triangle is a type of periosteal reaction seen with aggressive bone lesions. Here, the periosteum does not have time to ossify with the shells of new bone, so only the edge of the raised periosteum will ossify. It was first described by Reber in 1914. However, it is named after the American surgeon Ernest Emery Coleman, who described it in the setting of Evans sarcoma. This is a 30-year-old man presented with gradually increasing swelling and pain in the left leg for 6 months. There is a large soft tissue mass with the malignant bone formation in the right leg above the knee. The right femur shows extensive and aggressive vertical periosteal reaction along the proximal disc faces, and extends perpendicularly from the inner cortex to the outer margin of the tumor. You can also see cortical erosion and cortical thickening, suggestive of intramedullary extension. Here we have another typical case of osteosarcoma of a 27-year-old man with bone pain in the left leg for 8 months. Please pay attention to the aggressive periosteal reaction, Coleman's triangle, along the distal diaphysis of the left femur, cortical erosion and thickening, as well as soft tissue swelling. By contrast, it is a lytic osteosarcoma in the distal femur. AP X-ray shows an extraosseous mass and a proximal Coleman's triangle. Please note that the lytic lesion destroyed the cortex completely. Let's move on to this case. AP and lateral X-ray of the distal femur showing dense sclerosis due to an osteosarcoma and a vertical periosteal reaction arising from the medial metaphysis. Although plain radiograph can provide a lot of information, MRI is invaluable for local staging by assessing intraosseous tumor extension and soft tissue involvement. This is a lytic osteosarcoma in the tibia. Sagittal fat subplexity imaging on your left shows an irregular hyperintense lesion in the proximal tibia, marked by yellow dotted line, as well as an associated soft tissue mass, red arrow. The intramedullary lesion crosses the growth plate into the epiphysis, red star. The image in the middle is the sagittal T1 weighted without fat suppression, which shows heterogeneous hypointense changes in the tibia. The one on your right is the sagittal fat supply T1 weighted imaging after contrast injection. The tibial sarcoma shows an uneven enhancement. CT adds little to plain radiograph and MRI in the direct assessment of the tumor, but it is superior to both in depicting the bone margins. The CT imaging shows a mixed osteolytic and sclerotic osteosarcoma in the proximal tibia. As you can see, there are irregular cortical destruction, aggressive periosteal reaction, Coleman's triangle, and a soft tissue mass with malignant bone formation. Here is another CT of an osteosarcoma in the left ilium, showing irregular cortical destruction, aggressive periosteal reaction, and a large soft tissue component, again with osteo formation. To conclude, the diagnostic key points for osteosarcoma include bone destruction, aggressive periosteal reaction, soft tissue mass, malignant bone formation, and sadly, usually found in young patients. General differential considerations include osteomyelitis, bony metastasis, even sarcoma, and aneurysmal bone cyst. Accurate diagnosis depends on needle biopsy. That's all for this session, and these are useful learning resources. Thank you for your attention.